Okay, good evening, everybody. Welcome to my webinar on adrenal insufficiency, how to diagnose and treat. Everybody here okay?
Yes.
Yes.
Okay, you see the slides?
Yes.
So we're going to talk first about how to diagnose. My guess is it will take about a half hour. We'll have time for some questions after that, and then we'll do how to treat. That will be another half hour, and then we'll have questions for both parts of it at the end. I am recording this, and I should be able to put this on my website in the next couple of days. And if you've joined and I haven't told you, please mute your phone or your computer so it doesn't make too much background noise. And then when it's your turn to ask the questions, then you can unmute yourself. And again, write down your questions if something comes up there in the middle, during the talk, and we'll get to them in the middle there. So the title is Adrenal Insufficiency, How to Diagnose and Treat. The adrenal glands lie at the top of each kidney. They're composed of two distinct regions, the cortex and the medulla. The adrenal hormones are glucocorticoids. The predominant one in humans is cortisol, mineralocorticoids, aldosterone, androgens, DHEA and DHEAS, the sulfated form, testosterone, androstenedione, there's estrogens, and there's catecholamines made by the adrenal medulla, epinephrine, and dopamine. Cortisol is the main hormone. It has a daily secretion of around 10 to 50 milligrams per day. It has a circadian cycle, and I'll show a slide of that shortly, with the highest level at around 8 in the morning. It has three forms. The free form is about 5%. It's physiologically active. It's bound to cortisol binding globulin, and albumin is the majority of it. And you also have cortisol metabolites that often are not bound to cortisol binding globulin or albumin. But it is the free form that's biologically active. The brain hypothalamic pituitary axis regulates cortisol. It has a circadian rhythm, and stressors such as hypoglycemia, hypertension, surgery, fever, or injury regulate the secretion of CRH to the hypothalamus. It goes to the pituitary, and CRH, along with vasopressin and pro-inflammatory cytokines, lead to the secretion from the pituitary of ACTH. The ACTH goes to the adrenal glands, which then secrete cortisol. Cortisol has a negative feedback on both the pituitary to decrease ACTH secretion and the hypothalamus to decrease CRH secretion. The renin-angiotensin-aldosterone axis regulates aldosterone. The liver makes a prohormone called angiotensinogen, which is 452 amino acids. It gets cleaved by renin, primarily in the kidney and also in the bloodstream, to give angiotensin 1. Renin itself is made as prorenin and has to be activated for renin. Angiotensin 1 is 10 amino acids, and it gets converted by angiotensin converting enzyme in the lung and the plasma to angiotensin 2, which is 8 amino acids. That binds the angiotensin 2 receptor, and there's several places where the angiotensin 2 receptor occurs, in both the adrenal gland where it stimulates aldosterone, and in the vascular blood supply where it causes constriction of the veins and the arteries. Glucocorticoids have multiple actions. They maintain metabolic homeostasis. They do this by raising blood glucose levels, which is why they're called glucocorticoids. They raise insulin levels. They increase catabolism, meaning the breakdown of proteins, and they decrease anabolism, building up of proteins. They inhibit the reproductive, thyroid, and growth hormone axes, and they have mineralocorticoid activities of cortisol itself. Glucocorticoids also affect connective tissue. They cause loss of collagen, loss of connective tissue. They inhibit fibroblasts and inhibit bone formation and increase bone reabsorption. They maintain cardiovascular function by increasing the heart output, cardiac output. They increase your blood pressure. They have a permissive tone effects on other hormones that raise your blood pressure, and they cause increased sodium retention. They have multiple effects on behavior and cognition, and they affect the immune system. They decrease the number of circulating lymphocytes, monocytes, and eosinophils, and decrease the migration of polymonocytes to the site of injury, so therefore they usually decrease the immune system, and they regulate about 25% of the human genome, so they're extremely potent and important hormone. This is the circadian rhythm of ACTH and cortisol, and you can see that the majority of cortisol is made around between 6 and 8 in the morning. It declines throughout the day. There's a little bit of a meal-associated increase of it, and the ACTH somewhat follows it as well, with maybe a little bit more noise. But the important thing to note is most of the cortisol is in the morning, and it declines throughout the day and is quite low overnight. Somewhere around 3 in the morning it starts rising again, somewhere between 3 and 6. Angiotensin II is a vasopressor. It raises up the blood pressure and also stimulates aldosterone. Aldosterone activates the sodium-potassium pump in the kidney, increases plasma sodium, decreases plasma potassium, and decreases plasma hydrogen. There are different types of glucocorticoid insufficiency. This is very important to note. There's primary adrenal insufficiency, where one's adrenals are not working. You get a deficiency of both the glucocorticoids, cortisol, and the mineralocorticoid, aldosterone. You have a compensatory increase in melanocortin, which is a precursor for ACTH and which can lead to hyperpigmentation. That's primary adrenal insufficiency. You can have secondary adrenal insufficiency, where you only have glucocorticoid itself that is affected. This happens in the pituitary problem. And you can have glucocorticoid withdrawal. Somebody's on glucocorticoids chronically, it's stopped or tapered off. You can have low cortisol, and again, the aldosterone is unaffected in glucocorticoid withdrawal. Here's a picture of hyperpigmentation, both along the teeth and in the mouth. The different causes of primary adrenal insufficiency are autoimmune, which is by far the most common in the United States. That's called Addison's disease when it's autoimmune. Tuberculosis is the second most common cause in the United States, and probably the most common cause worldwide. Fungal disease, AIDS, and HIV virus and other associated viruses like CMV and MAI, the bacterial infection that occurs in AIDS, can also give adrenal insufficiency. Metastatic cancer, adrenal hemorrhage, bilateral adrenalectomy, patients that had surgery for Cushing's disease, and they remove their adrenals, for example, can get adrenal insufficiency or do get adrenal insufficiency. Agents which inhibit cortisol biosynthesis, of which ketoconazole is the most well-known one, and sepsis can also give you adrenal insufficiency, overwhelming infection. Secondary adrenal insufficiency occurs when you have a pituitary problem, but it's important to note that the corticotrope cells, the cells that make ACTH, are the most preserved cells in the pituitary, and they are usually unaffected. Pituitary tumors can give secondary adrenal insufficiency, radiation, surgery, pituitary apoplexy, where the pituitary has a mini stroke after delivery. It's called Sheehan syndrome. You can have infiltrating diseases such as histiocytosis X that can give you pituitary problems. After cure from Cushing's syndrome, you can have adrenal insufficiency, and after glucocorticoid withdrawal is probably the most common reason of having secondary adrenal insufficiency. Symptoms of glucocorticoid insufficiency, and I think it's important to note the difference between glucocorticoid and mineralocorticoid insufficiency. Symptoms include fatigue, vomiting, diarrhea, anorexia, low appetite, malaise, muscle and joint pain, abdominal pain, weight loss, hypoglycemia, low blood sugar, and low sodium because of the excess ADH type of picture that gives you low sodium. And again, it's important to note these symptoms.
Glucocorticoid insufficiency.
I'm sorry?
Yeah, that's me.
As they are, what you want to look for if you're suspecting adrenal insufficiency, that you should only do testing if the person has some or all these symptoms. On the other hand, symptoms of mineralocorticoid insufficiency, such as aldosterone insufficiency, you're dehydrated, you have decreased intracellular volume, you have low blood pressure, you can go into shock, you have low sodium and high potassium. The high potassium can lead to arrhythmias. You have acidosis, your blood is acidic, and you have salt craving, which is one of the most common symptoms of mineralocorticoid insufficiency. Laboratory findings of patients with primary adrenal insufficiency would be low sodium, high potassium, low blood sugar level, excess lymphocytes, excess eosinophils, and a anemia that the cells are normal size. So it's called a normocytic normochromic anemia. There are different stages in the development of primary adrenal insufficiency. Initially, the renin, the hormone made by the kidneys, when you have low aldosterone, rises, and the aldosterone is normal. Next, the ACTH rises, and the cortisol is normal. You then have an impaired cortisol response to ACTH. Your aldosterone levels drop, and the last stage is your cortisol levels drop. This is a picture published in Journal of Clinical Endocrinology and Metabolism, showing that you initially can have antibodies present, increased resting plasma renin, raised afternoon ACTH, decreased ACTH stimulating cortisol response, decreased aldosterone, decreased cortisol and aldosterone, and you may need to have 90% of the adrenal destroyed before you start getting the effects of some of these effects. When you're trying to ascertain the diagnosis of adrenal insufficiency, the first thing to determine is whether there's low cortisol, and also if it's primary, if it's adrenal, if there's low aldosterone. And then you want to determine whether the cortisol deficiency is dependent on ACTH, meaning the ACTH is high, and you have adrenal insufficiency, or independent, the ACTH is low. First question again to look for is the cortisol level low?
I'm feeling well, so I don't know.
Most of the time you can check an 8 a.m. fasting cortisol level. Cortisol does go up after meals, so it should be fasting, and the 8 a.m. is when it's usually around the lowest. And if somebody has a cortisol level less than 5, or it's most likely to have adrenal insufficiency or glucocorticoid insufficiency. If it's greater than 12, most likely they don't. If it's in between there, then you have a gray zone that you need to do for the test. This test should only be done in patients with signs and symptoms of adrenal insufficiency or a history consistent with it. It can be used in those patients with a moderate index of suspicion, and then you can measure the ACTH levels, that if they're low, it indicates primary adrenal, if they're low, it indicates secondary adrenal insufficiency or pituitary adrenal insufficiency, and if they're high, it indicates primary adrenal insufficiency. A consistently high ACTH can be a sign of early adrenal insufficiency. My postdoc and I published that in 2004 of a patient that has early adrenal insufficiency, has a high ACTH with a normal cortisol. The patients that have a cortisol between 5 and 12, you often will want to do a cosentropin test again, especially if they have symptoms of low cortisol, as we talked about already. In a standard cosentropin test, you give 250 micrograms of IV cosentropin, which is synthetic ACTH. You usually do it any time of the day. Measure cortisol times 0, 30, and 60 minutes, and a cortisol value of 18 at any time after the initial test. The initial sample rules out primary adrenal insufficiency and rules out almost all of the cases of secondary insufficiency. If the peak response is less than 10, most patients will need glucocorticoid replacement. If the response is between 10 and say 18 and 20, the glucocorticoid replacement may be needed for stress, but may or may not be needed every day depending on the symptoms. I don't look at the change from the baseline of cortisol. If you start off pretty high, you often won't go up that much higher, so the delta or the change of cortisol is not recommended. And you need to have sustained hypocortisolism. If you have a pituitary problem, it needs to be at least about a month. So some articles say less, but I think a month is a good time before you get enough adrenal atrophy and you fail the test. The test works because ACTH is an adrenal corticotrophic hormone. It stimulates the adrenals to grow. You have low ACTH, your adrenals atrophy, and they don't respond to exogenous synthetic ACTH. Many people use the 1 microgram cosentropin test. It's proposed to be more physiological, and it will definitely pick up more cases of adrenal insufficiency, which you may or may not want. It may pick up patients that weren't picked up by the 250 microgram test, but it may also pick up patients that you don't want to treat and don't need to be treated, and therefore you should use it with caution. Lynn Lauria and Maria Fleshout pointed out in the editorial in 2009 that several problems with the test. One is it's on a steeper part of the dose response curve. There's more variation from it. It's really not known what normals should be and what the cutoff is for this test. And if you call somebody abnormal based on a blunted response to this test, and you put them on lifelong glucocorticoids, it may be the worst thing you could do to a patient. So you should be very cautious in interpreting this test. You can try to measure 24-hour urinary free cortisol or 17-hydroxysteroids, cortisol metabolates, but it's not that good at measuring low from normal, but it might give you a hint. If somebody has quite low urine, 17-hydroxysteroids and urinary free cortisol, it might be a hint they do have adrenal insufficiency. ACTH is the last hormone to be affected in primary insufficiency. In pituitary insufficiency. Growth hormone, TSH, and gonadotropins usually are lost before ACTH is. And therefore, if you're suspecting pituitary cause, you usually need to see these other hormones affected. Symptoms of glucocorticoid insufficiency are unique. They include weight gain, weight loss, nausea, abdominal pain, and therefore, if somebody doesn't have those symptoms, you should be cautious about interpreting these tests and putting somebody on glucocorticoids. Primary adrenal insufficiency is relatively rare and also has unique labs tests, including the high ACTH, high renin, low aldosterone, and low cortisol. Unless they have that combination, it's unlikely to do that primary adrenal insufficiency. Once started, glucocorticoids can be hard to stop and are often very detrimental. So if you have a test that is really low on one of the acostotropin tests or morning cortisol, it's probably good to repeat it unless it's really in the right context of what could be adrenal insufficiency. And I think you should think twice before going on glucocorticoids. Glucocorticoids stimulate the mood, so the fact that somebody feels better on glucocorticoids does not mean they really have adrenal insufficiency. The fact that they do a little better initially can't be used to prove the test. There's a lot of fiction about adrenal fatigue. It's widely proposed by alternative and anti-aging doctors, which I'm not. There's a lot of internet discussion on it. It's often based on salivary cortisol assays. Most of them are marketed directly to the patients, which are both lack the precision. They don't measure cortisol accurately, and they're not reproducible, so they have low precision and accuracy. The theory proposed by advocates of adrenal fatigue is that stress leads the adrenals to work harder and makes more cortisol, but then it burns out, or peters out, and makes less cortisol. Dr. Tori Hudson said it's like a hormone factory, and it wanes in its production. One of the ways it wanes is just by stress. Alternative doctors may give herbs and supplements to stimulate the adrenal gland, but they also gave isocort, which used to be ground up cheap adrenals, or herbs, or they often give hydrocortisone, and I think this could be dangerous. One alternative doctor said is a treatment for adrenal fatigue is eat lean, green, and clean, and I think that's a good advice for anybody, not just if they have adrenal fatigue or not. In reality, however, the facts are that adrenals are upregulated. They make more cortisol during stress and not less cortisol. There's a publication in Psychoneuroendocrinology in 2006 that studied 74 patients who were clinically burnt out individuals, which is the Dutch term for adrenal fatigue. Most of them were on sick leave and compared them to 35 healthy controls. They found similar salivary cortisol after weight gain at different times of the day and a similar overnight dexamethasone suppression test in the two groups. And really, patients should not be on cortisol unless they're shown to be adrenally insufficient. There's also a lot of myths about adrenal insufficiency and hypothyroidism, and I think it comes to the fact that both Addison's disease and Hashimoto's autoimmune hypothyroidism coexist frequently. They're part of type 2 autoimmune polyglandular syndrome, which is also called Schmidt syndrome. Also, if somebody has a pituitary problem, adrenal insufficiency and central hypothyroidism often coexist. Patients with full-blown adrenal insufficiency and hypothyroidism have to get glucocorticoid replacement prior to thyroid replacement. If they don't, the thyroid replacement can cause them to go into adrenal crisis. And this is because in hypothyroidism, cortisol metabolism is decreased because of this enzyme called 11-beta-HSD1, which favors cortisone to cortisol conversion. So they get very little breakdown of cortisol, they get a lot of regeneration of cortisol. Once you start treating hypothyroidism, you cause the low levels of cortisol to be broken down more rapidly, and it will lead to an adrenal crisis. And this is probably not true in patients with a borderline adrenal insufficiency, or adrenal fatigue, most patients don't need thyroid medicine. They may or may not need cortisol, but in the patients with full-blown adrenal insufficiency, you should definitely treat their adrenal disease before treating the thyroid disease. And their statements about needing cortisol to support thyroid replacement are missed. So this concludes the first part of the talk on adrenal insufficiency. We'll open up for about 5 minutes to the floor for questions, and you can either speak or let me see if we can get the chat going.
Hello?
I need to open it up to chat, but I don't, somebody's saying hello, hello. I don't see anything happening. What happened?
Is it possible if everybody can mute unless they're speaking, because there's lots of static, so it was really, really hard to hear what Dr. Friedman was saying.
Nothing's happening.
You need to put your phone on mute. Is there any way to do that?
I think there's someone that's on a phone that has like a lot of static. Really hard to hear anything.
I think whoever's not speaking, if they can mute their phone or mute their computer. I'm not hearing anything, so as long as everybody's muted, whoever is going to speak, unmute either their computer or their phone. Dr. Friedman, are you still there?
I have a question. Hello? I can't hear. Oh well. I think I'm just.
I wonder if he lost connection and he has to log
No, you
back
can hear me
on.
now. I can hear you. Hello, can you hear me?
Okay. Yes.
Okay. Go ahead.
I was wondering, one of my tests, it said I had 3.04 cortisol level, and my doctor didn't even seem to think anything was wrong with me, and I'm constantly about to pass out and all this stuff, and I wonder why she keeps saying that, like, nothing's wrong with me. It's really bothering me.
So I guess the first question is, was it done in the morning or in the afternoon?
They did it incorrectly, I think, because it was in the afternoon, but my morning one recently was 8.27.
Yeah, so that's on the borderline side. I would have your doctor do a costotropic test in this case.
Okay. Yes, he did actually do an ACTH stim, and my baseline was the 8.27. And have a look at it. So that's borderline?
That's borderline. It's not too bad in the morning. But your symptoms sound like you could have it. It also sounds like you could have aldosterone deficiency. Remember, aldosterone is a hormone that that regulates your salt, and people with low aldosterone have low blood pressure and pass out a lot. So you might want to measure your aldosterone and renin and start by taking in more salt.
Okay. Thank you.
I have a question.
Okay.
I have Sheehan syndrome. My pituitary is completely gone, so I need to replace every single one of my hormones. Like all my hormones are my cortisol was like basically almost zero. I take 25 a day of the hydrocortisone.
Okay.
And I know that there's also other medications that I take, but they're for not for the adrenals. But that's the only adrenal medication that I take. Besides for DHEA that the doctor said that you can only buy over the counter, so there's no pharmaceutical company that actually makes a prescription medication for it. So I was wondering if you said there's 5 different adrenal hormones, why would the doctor only give me hydrocortisone, only to replace the cortisol?
Right. All right. So you have secondary adrenal insufficiency,
Right.
which means your pituitary is not working, and the pituitary regulates only the cortisol. It doesn't regulate the aldosterone for the most part. Occasionally there's some role of aldosterone. It does regulate DHEAS, and I think it would be reasonable to take DHEA. You can get it over the counter. 25 milligrams is a reasonable starting dose. You can get it from a compounding pharmacy. But I think taking DHEA is reasonable. You can have your testosterone check, and you can then see if your testosterone is low. You might want to take testosterone back. The epinephrine and the dopamine from the adrenal medulla aren't regulated by the pituitary and usually aren't replaced. So I think in your case, it's important to be on the cortisol. We'll talk about cortisol replacement in the second half of the talk. And it's important to make sure your pituitary is properly replaced. And then I think taking the DHEA would probably help.
So I did have lab tests for testosterone. My testosterone was 1, but she said that it doesn't matter because it only matters in men.
Right. I would probably come to see me. I think you need a little bit more expertise in this. I think there's significant data about women with hyperpituitarism, low testosterone, improving on it, and I think you'd be a good case with to take testosterone.
And what about the DHEA? She told me to get it over the counter. She also said, like you said, 25 milligrams. And when I took it, it caused a lot of acne. So I lowered
so I would probably go down to 10 milligrams then. Your body's people are very sensitive to it, and 25 may be too strong. Try corn.
And 10 milligrams is enough?
It should be. 25 is too much.
In my lab test, my DHEA was extremely low, and I am 26, and I am worried about, like, I don't want to, like, get old, you know?
Right.
So you think 10 would be enough?
10 would be a good starting next one as well.
And what test do I do to test my aldosterone?
Aldosterone and renin.
You just test them in the blood or in the urine?
Blood test.
Blood
in the
test.
morning, probably. Doesn't matter that much.
Okay. Thank you.
Can I ask a question?
Sure.
I just got diagnosed with secondary adrenal. They tested my, the first time I tested, my cortisol was at 1.5, and my ACTH was at 7. So they did this ACTH stim test, and my baseline was around 2, and I stimulated up to a 7. Now, is that enough stimulation to show that it was a pituitary compared to adrenal?
Right. So I think you need to, just like the other person asked before, you need to measure your ACTH level. If it's low, it suggests pituitary. If it's high, it suggests adrenal. You should measure your aldosterone and renin. If they're normal or both a little bit low, it's pituitary. If your aldosterone is low and your renin high, it suggests adrenal.
Okay.
And then you also have to see if you have any other pituitary problems. Like
yes, I take growth hormones right now.
Or no menses or something like that.
Right. I also take growth hormone injections every day also.
Right. So it sounds like you have pituitary.
Right. And my DHEA had dropped to like 0.5. Is that a normal drop for this kind of issue?
Yeah, so most patients with pituitary problems and hypopituitarism have very low DHEA.
Okay. Okay.
DHEA.
All right, thank you.
Okay. So let's move on here. We'll get to Kathleen and Elizabeth's question at the end here, and keep writing down your questions for the second half. Move this over to the side. Okay, so the daily cortisol production rate it was published in about from the NIH in 1991 was about 10 milligrams per day, about 5.7 milligrams per meter squared. So somebody that's larger and taller does often need more cortisol replacement than others. So 9.9 is pretty low. That's how much the body makes. Not all the oral cortisol is absorbed, so you usually have to take somewhere between 12 to 15 if it is taken orally. We'll talk about other routes. Therefore, most people are on higher doses than 12 to 15 a day. Most of the time, people are on too much glucocorticoid replacement. Too much glucocorticoid replacement can lead to osteoporosis, glucose intolerance or diabetes, and increased infections. If you're truly on the right dose, it's likely to be tolerated pretty well. But again, it's always better to not take a medicine you don't need it, but certainly if you need it, and the people who do need cortisol definitely need it, if you properly replace it, it's more likely to be benign. This is very important to understand the different doses of the glucocorticoid. About 20 milligrams of hydrocortisone is the average dose. It's equivalent to about 15 milligrams of IV fludrocortisone. Again, the IV medicines are, you don't lose stuff because you don't absorb it properly, so you can usually get by on a little bit less. You take, that's equivalent to about 4 to 5 milligrams of prednisone, 4 milligrams of methylprednisolone, 0.75 milligrams of dexamethasone, and there is a liquid dexamethasone which I found very helpful in several patients at 0.5 milligrams per 5 mils. You can use just a little less liquid and titrate these down, and each of these can be used and may be better in some patients. The hydrocortisone is the shortest acting one. The solid cortef is like hydrocortisone, short acting. Prednisone and dexamethasone are longer acting and therefore can be given once a day, but also don't quite mimic the circadian rhythm when most of the cortisol is given is high in the morning. And if you take hydrocortisone in the morning, it sort of mimics the circadian rhythm. Well, if you take dexamethasone or prednisone, it lasts a little longer throughout the day. Most patients are over-replaced on glucocorticoids. The earliest manifestation of excess treatment is easy breathability. Weight gain and central obesity also can occur. And the earliest manifestation of inadequate treatment is joint pain, nauseousness, and abdominal pain. It is reasonable to mimic the circadian rhythm or most or all of the cortisol given in the morning although I think many patients need more of it, need some of it in the afternoon. In general, you want to avoid large doses at night as it could lead to sleep disturbances. But as I'll show in the next slide, I did research several years ago showing that most patients need a bit of hydrocortisone at night or cortisol at night to go into deep sleep. Unfortunately, there's been no studies comparing different treatment regimens. In the 2000, right when I finished at the NIH, we published a paper looking at the role of cortisol in sleep regulation. We kept Addison's patients, and we found that Addison's patients, they need cortisol to go into REM sleep, and it may help to consolidate sleep. And I think most patients with adrenal insufficiency need a little bit of hydrocortisone before they go to bed at about 2.5 milligrams, and I am starting recommending this in all my patients. And this also helps, it helps lower the ACTH overnight a little bit and doesn't keep you awake, and is usually a good option. So my approach is to start with hydrocortisone mainly in the morning. I usually aim for a dose of about 15 to 20 milligrams a day in women and slightly higher in men, and then try to taper down. For example, you can give hydrocortisone 10 to 15 milligrams in the morning, 2.5 milligrams to 5 milligrams around mid-afternoon, and 2.5 milligrams at bedtime. Occasionally, an additional dose at 5 p.m. is needed, and then you would move that mid-afternoon dose to around noon. And you can decrease the dose until symptoms develop and then go back up a dose. Small changes make a huge difference. And cortisol is such an important hormone that a little bit difference, a little bit even in the formulation, can make a big difference. You want to increase the dose with illnesses, and we'll go over that a little bit. Short term, it's better to err on giving more if you have adrenal insufficiency crisis. Long term, you want to try to give less. And dosing is crucial, and there often is a difference between brands and generic. Cortef is brand name. It is often not covered by insurance. It can be expensive. Hydrocortisone is generic. When you just write hydrocortisone, the pharmacy can substitute different suppliers without telling the patient or the doctor. There are different brands, and the one from Core Pharma is a brand of generics that patients often like. It used to be called Glades, and it went about, I think in 2011, it went out of business as Glades. It's now called Core Pharma. Other brands include Greenstone, Qualitas, and Westward. It seems like Qualitas people like the least of them. Greenstone is fairly popular. Westward is somewhere in the middle there. All the pills come in 5, 10, and 20 milligram pills. So depending on your dosing, you want to be on either a 5 or 20. Sometimes you need to be on 10. But you want to stick with the brand you like and make sure that the pharmacy gives you that one if you are in generics. Okay, there's a lot of questions about glucocorticoid pumps, including some we had on the chat. There was a very nice article published in Journal of Clinical Endocrinology and Metabolism in May 2014 entitled Continuous Subcutaneous Hydrocortisone Infusion versus Oral Hydrocortisone Replacement for Treatment of Addison's Disease, a randomized clinical trial. It was published mainly from Norway, and the objective of the study was to compare continuous subcutaneous hydrocortisone infusion, and they used that abbreviation CSHI with conventional oral hydrocortisone OHC replacement. And it was a crossover randomized trial, meaning that each person got both of the group, multi-center trial, and it was a 3 times a day oral hydrocortisone versus the continuous subcutaneous hydrocortisone. It was from Norway and Sweden. 33 patients were enrolled from registries and clinics, and all patients were assessed at baseline and after 8 and 12 weeks of each treatment arm. They used as an endpoint ACTH levels, which has some of the problems, as in general you don't want to normalize ACTH, so that was the primary outcome. They also used effects on metabolism and health-related quality of life, surveys, sleep, and safety. Their overall conclusions, and I'll try to go over a little bit in more depth, but the continuous subcutaneous infusions yielded normalization of morning ACTH and cortisol levels and this 24-hour salivary cortisol curve that resembled a normal circadian variation. Urinary concentration of glucocorticoid metabolites displayed a normal pattern with the subcutaneous route, but were clearly altered in the oral route. Several quality of life indices and vitality domains, sort of meaning you have less fatigue, improved over time with the subcutaneous route. No benefit was found for either treatment for any subjective measurements of sleep or objective sleep parameters. This is the study design that they got dose adjustment based on what they were on before. They had a washout period, and then they were randomized into either the oral or the subcutaneous doses. They were then washed out and went back to their regular dose for a while, and then went on the other arm for the remainder of the study. During the continuous subcutaneous infusion route, they received hydrocortisone. They actually used solid Cortef and Acto Vial, which is what I give to many of my patients as an emergency, and it was administered by a standard insulin pump. It's interesting, they got an average of, they got 10.5 milligrams per meter squared per day. With the dosing, it's very interesting how they did the dosing. From 8 a.m. to 2 p.m., it was 0.5 milligrams per meter squared per hour. So that was the sort of morning to early afternoon dose. From 2 p.m. to 8 p.m., they got a lower dose of 0.2 milligrams per hour. From 8 p.m. to 2 a.m., they got a 0.05 milligrams per meter squared per hour, so very low spin. And then they got their highest dose from 2 p.m. to 8 a.m., 2 a.m. to 8 a.m. at 1 milligram per meter squared. This to me seems like a pretty high dose overnight. It's very important to see how they did the dosing. They then adjusted it based on salivary cortisol levels, both in the morning and in the evening, and morning serum cortisol levels. So they did do a dose adjustment based on what the patient's levels were, and they aimed for morning salivary cortisol in the mid to upper range, a normal morning serum cortisol level, and an evening salivary cortisol level in the lower reference range. The oral treatment was weight adjusted and given 3 times a day at 5 milligram pills, and it was based on what the serum cortisol showed 4 hours after the morning dose on days 3 through 5. So the titration wasn't nearly as good with the oral as it was with the subcutaneous. Here's the graphs of the results. The first one here, and the black lines are the subcutaneous, and the grayer lines are the oral. So first is the ACTH level. The ACTH level started at about 120, and in the oral level, it actually went up a little bit, really no change. And in the continuous, mainly because they got that hydrocortisone overnight, their morning ACTHs went down almost to normal here. This is their morning cortisol level, and you can see at 8 a.m. here, they started at baseline, they were low, and then because most people take their medicine right at 8 a.m., they got a much higher morning cortisol level in the subcutaneous, the pump route. While they were on orals, they got a very low morning cortisol over here. You can see here the salivary cortisol levels. That the black is the subcutaneous infusion. It sort of mimics the circadian rhythm per day fairly well. The orals had a little bit lower overnight in the morning expected, a little bit higher in the mid-morning after their dose, a little peak after their other dose, another peak after the final dose here, and it wasn't nearly as smooth as the subcutaneous. Here's the salivary cortisone levels, which I think is also a good way to measure this, although I'm not sure how commercially available it is. The group that got the subcutaneous levels, the insulin infusion with the insulin pump, they went up much more overnight and early morning, they're much higher, while the ones that got the oral stayed down low here, and then the rest of the day they were fairly similar here. So the morning levels decreased during the continuous infusion and remained high during the oral, and the morning cortisol and cortisone levels were reference range, but were low in the oral group. The morning salivary cortisone levels were higher on the continuous group here than on the oral group. In general, there was no significant difference in weight, waist to hip ratio, or blood pressure reserve, although there was a tendency, this is very important, toward an increased weight and body mass index, gaining weight in patients on the pump. So this, I think, is going to be a big negative about the pump, that it can give you a little bit more weight gain in the oral. Morning glucose levels also got a little worse. This is probably detrimental. You don't want to get pre-diabetes from your pump. So they were a little bit, they were higher with the pump than they were with the oral. There was no difference in sleep parameters. Here's the quality of life survey. They did something called an ADDI quality of life survey, and this is over here. The patients on the pump In the dark circles, it went up their quality of life, meaning they had less fatigue and their quality of life was better. The patients on the oral stayed about the same. This one here is a vitality score based on this PGWBI. Their vitality, which means a little more energy, went up with the pump and stayed about the same on the oral. And finally, their physical function score also increased on the pump and stayed about the same and went down on the orals. So the conclusions is this pump can be used safely. It's probably fairly difficult to use, and again, you have to get an insulin pump. There may be a cost involved with it. There's a lot of cost of the tubing, and we're not sure whether insurances will pay for this. Right now, it's only published in one article. The high ACTH in the patients with Addison disease may be detrimental and is due to the lack of cortisol replacement overnight. This idea about starting replacement at 2 in the morning was probably too early. They recommended a revision in their discussion to start it at 3 in the morning, and they think this is going to be better. But giving some hydrocortisone at night, as I recommended, before you go to bed may help decrease that ACTH in the morning. And in certain patients, you may need to maybe wake up, that are on the oral, you may need to wake up in the middle of the night and take some, maybe a little before you wake up in the morning. Some patients I recommend setting their alarm at 6 in the morning and starting it, some hydrocortisone orally, but I think 3 a.m. is what this paper recommended. There was less fatigue but some weight gain with the pump, and I would reserve the pump for those who failed oral hydrocortisone and at least one other steroid preparation. We talked about the idea about using liquid dexamethasone or prednisone or even Solu-Cortef, which is given IV and can be given to somebody who has a PICC line or something like that. That might be better than giving this pump. There is an investigational drug called Duocort. It combines a rapid release dose and extended release form. It can be given once a day with the idea that it better mimics the circadian rhythm. Their website about this, and there have been some papers published this, that the existing administration form can't adequately mimic the circadian rhythm of cortisol. This is probably being used in congenital adrenal hyperplasia, but it may be also used in adrenal insufficiency patients. And I'm not sure that all the patients with adrenal insufficiency need this. There's something called the cortisol-cortisone shuttle, which cortisol-cortisone shuttle, which if you have adrenal insufficiency and you measure cortisol in the afternoon, it could be quite low, but the patient doesn't have that much, doesn't have adrenal insufficiency. It's probably because the cortisol goes to cortisone, which is like a storage form of cortisol, and then goes back to cortisol when it goes into the blood. Most patients do fine on a single dose of cortisol or a couple of doses, even though blood cortisol levels are 0, and this is because they get the conversion to cortisone, which is then as a storage form. This Duocort is very expensive currently. I think it is approved, but it is quite expensive. In general, my approach for maintenance therapy for primary adrenal insufficiency is patients with primary adrenal insufficiency may need a little bit more glucocorticoids than those with secondary or pituitary. Mineralocorticoid replacement is crucial. The dose of hydrocortisone we talked a lot about, but the dose of fludrocortisone is given in adrenal insufficiency and varies widely between 0.5 milligrams to 0.5 milligrams twice a day. It should be given twice a day as it has a pretty short half-life. I'm not sure why many endocrinologists don't do that, but really the fludrocortisone should be given twice a day. The side effect from it seems to be a little bit of a headache and some swelling, but most people tolerate it quite well, and it's a much more benign medicine than glucocorticoids. Fludrocortisone is a generic name. The brand Florinef is not available, so basically it's just called fludrocortisone, and most people need more fludrocortisone in the summer and less in the winter. Patients, especially those with primary adrenal insufficiency, should get a MetaAlert bracelet. Patients with secondary have less adrenal insufficiency and may also benefit one, but I don't think it's crucial, as also with primary adrenal insufficiency. Solu-Cortef in 100 milligrams in active vial should be given to every patient because if they get into adrenal insufficiency, they should give themselves a shot and go to the emergency room. How to monitor glucocorticoid replacement. The main thing is signs and symptoms. Excess glucocorticoids we talked about before include weight gain and bruising, stretch marks. You can measure 24-hour urinary free cortisol. It often overestimates cortisol as it reflects the amount in the urine right after dosing that exceeds the ability of the kidney to break it down by this enzyme called 11-beta-HTP2. The 17-hydroxysteroids can be corrected for creatinine, and those are usually a more reliable measure. This is cortisol metabolites and reflects cortisol metabolism in more throughout the day. The cortisol day curves probably underestimate cortisol as it ignores the cortisol-cortisol shuttle, and if you follow them, you'll be told to take more. It's probably not that accurate. Probably measuring salivary cortisol might be a better way to do it, and I think we're going to look into ways to have that done commercially. ACTH is usually high unless you're on that pump or you're over-replaced. An example of monitored glucocorticoid replacement is patient LW, a she-and single patient who is very athletic and health conscious. We tapered her hydrocortisone from 20 milligrams a day to 17.5 milligrams a day. She was taking 12.5 milligrams in the morning, 5 milligrams in the afternoon. She had less bruising and slight weight loss. Her urinary free cortisol on 17.5 milligrams was elevated at 191 a day. The 17-hydroxysteroids were perfect, and the 17-hydroxysteroids per gram of creatinine were sort of high normal. She went down to hydrocortisone, 15 milligrams a day, and she had an adrenal crisis when she had the flu. So monitoring this can be very difficult. From 17.5 to 15 makes a big difference in terms of your susceptibility to adrenal insufficiency as well as how you're feeling. Monitoring mineralocorticoid replacement is rather easy in primary adrenal insufficiency. The plasma renin activity is very accurate and should be measured probably every 2 to 3 months. If it is high, more fludrocortisone can be given. If it is low, less fludrocortisone can be given. Electrolytes are relatively insensitive and should not be substituted for frequent renin monitoring. There are hormone interactions. Increased growth hormone or IGF-1 leads to lower levels of cortisol because of this enzyme, the 11-beta-ACP1 enzyme that breaks down cortisol. If you're treating a patient with hyperpituitarism, you start adding on growth hormone, you could decrease the cortisol level. Similarly, if you're treating a patient with hyperpituitarism with thyroid hormone, you'll decrease the cortisol levels. And I had one patient that was over-replaced on glucocorticoid, under-replaced on thyroid, and under-replaced on growth hormone. We started her growth hormone, decreased her glucocorticoids, increased her levothyroxine, and she went into an adrenal crisis. So make changes slowly and monitor frequently, especially if you have hyperpituitarism. If you have a minor illness, such as a fever greater than 100.5 and vomiting, you should double your glucocorticoid dose. If you have severe illness, you should give 100 milligrams of IM hydrocortisone in your short solid cortisol vial and either go to the emergency room or your acute care or your doctor immediately. Adrenal crisis is usually occur in patients with primary adrenal insufficiency, more so than pituitary. They usually participated by stress, illnesses, infections, and they could be in a newly diagnosed patient or an established patient who stopped his medicine, was vomiting and couldn't take his medicine down, or has a concurrent illness. Patients with adrenal insufficiency, usually primary adrenal insufficiency, they often have low blood pressure, they can have hypertension, they can have shock, abdominal pain is very common, fever, anorexia, we need low appetite, nauseousness or vomiting, confusion, low sodium, high potassium, acidosis, and low blood sugar is rare. If somebody has adrenal crisis, they should go to the emergency and get an IV fluid. They should get bloods drawn for electrolytes, cortisol, glucose, ACTH, aldosterone, and renin. They should get IV saline up to 3 liters. Follow the fluid status. They should get IV cortisone, and they should be looked up for infections and heart problems and other supportive measures. Patients going to surgery, it's a big question about how much patients should get. A normal adult during surgery makes more cortisol, 50 milligrams per day during minor surgery, 75 milligrams to 100 milligrams during the major surgery. A lot of this is due to anesthesia. And it's common practice to give what's called stress dose of glucocorticoids perioperatively with scant evidence to support this practice. In 1950s, 2 young patients with glucocorticoids died unexpectedly during orthopedic surgery, and this has led to this idea about stress dosing during surgery. The risk of excessive glucocorticoids include reduced tissue repair, increased susceptibility to infections, and glucose intolerance. So what I recommend during moderate illness, 50 milligrams of hydrocortisone twice a day. Severe illness, 100 milligrams of IV hydrocortisone every 8 hours. a minor procedure without anesthesia, probably no covered. Moderately stressful procedures like endoscopy, colonoscopy, or arteriography, 100 milligrams of IV hydrocortisone prior to the procedure, and maybe 50 milligrams after the procedure. A major surgery, 100 milligrams of IV hydrocortisone before anesthesia and every 8 hours for a couple of days. If you want to schedule an appointment to see me or have more questions, feel free to contact us at look at our website, goodhormonehealth.com, and send us an email or send a phone call to Lynn. And now we'll open up to some questions on the second half and some overall questions on the whole talk. And we'll start off with some of these chats. I think we've got a couple of.
Could I ask? I have a question.
Sure, go ahead.
Yes, in regards to the pituitary adrenal insufficiency, I had, when I got diagnosed with the growth hormone deficiency, they did, this MRI on the TESA-3, and, it did not have any kind of tumor on the pituitary. And from then, all my other hormones have obviously dropped off, with the adrenal insufficiency being the last one here. How important is it, if I don't have a tumor, to find the reason for the deficiencies, or is it really not important as long as I don't have the tumor?
Well, I think it is. If you can't, try to find the reason. I mean, I think that if you either have Sheehan syndrome, you have a small pituitary MRI, I would say it's unusual to have panhypopituitarism, including cortisol deficiency, without anything structurally wrong. It's possible, but it's a little unusual. So I think you should, they should at least look for other causes of why you have hypopituitarism.
Okay.
Trauma, Sheehan's, infections in your pituitary, things like that.
Okay, because I first went the growth hormones, then the thyroid, obviously FSH and LH, and now this last thing of of the insufficiency now. So you're thinking that my doctor should realistically look for another look for a reason if I don't have the Sheehan's or anything like that.
Right.
Okay. Thank you very much.
Okay. Lisa asked about liquid dexamethasone versus oral dexamethasone. And I think that's an excellent question. I've only started using liquid dexamethasone recently. I think the whole issue comes about is patients with adrenal insufficiency, some of them, either from thyroid or something else, they just don't absorb their pills well. And they have poor absorption. So anytime they're taking a pill, they may not absorb it as well. Maybe they have gastritis in their stomach, things like that. People that had gastric bypasses may be another problem. So when you take an oral preparation like oral dexamethasone, it's often better absorbed, and it's much easier to titrate the dose. I mean, you can do the number of milliliters. You can do a dropper. You can adjust it very easily. The oral comes with a little measuring spoon, and you can adjust it very easily. Whereas dexamethasone basically comes as 0.5 milligram pills. It's much harder to adjust. I think this also brings up the issue that one of my patients, a couple of my patients, have been on IV hydrocortisone. They either have some kind of port in place or some kind of hep lock or something like that. They can take it in IV, and again, this makes it easier to absorb. Patients that have GI problems are feeling horrible, they're nauseous and vomiting because they have adrenal insufficiency. If you can give it to them by a IV route like through a port, hydrocortisone is a great choice.
Hi, can I ask a question?
Go ahead.
Hi. If someone has a pituitary issue that's causing hyperthyroidism, can it cause them to have secondary adrenal insufficiency?
Causing them to have hyperthyroidism?
Yeah.
Hypo.
Like secondary? No, hyper. Like secondary hyperthyroidism?
Well, secondary hyperthyroidism is rare. You have to have a TSH secreting tumor, and they are extremely rare. So you can be on over-treatment if you have hypo, which then could cause you, if you have adrenal insufficiency to begin with, it can cause you to break down your cortisol more than you wouldn't, but it wouldn't cause, adrenal insufficiency out of the blue.
Well, I'm asking because recently I had blood work that showed that I had high T3, high T4, as well as high TSH, but I've never been on thyroid replacement. And my ACTH was, I think, normal, but my cortisol was 5 in the morning. So I was curious if that could be a reason to cause secondary, if that could actually cause like fluctuating cortisol, like high cortisol,
I don't think so.
But also, no?
I don't think so. I think you need to be worked up on why you have the high TSH and 3T4 and 3T3. You know, you might want to get a pituitary MRI, see if you have a TSH secreting tumor, but they're very unlikely.
Okay, but so would that be a direction to go then, or would that just be kind of too rare?
Yeah, I think so. Yeah.
Okay. Okay, thank you.
Okay, so then we have a question about the MetaAlert bracelet. I would say it's good to have a MetaAlert bracelet for everybody. I think very few of my patients with pituitary adrenal insufficiency go into crisis. But, you know, you may, so I think it's always better to get it than not. Alicia talks about that she has a pump, and they are covered if they're covered by diabetic patients. The pump itself is trickier since it requires a prior authorization. They can obtain it usually, occasionally. If the plan covers hydrocortisone, they will cover. She has a pump and pays about $150 per month, $150 to $200 a month total, and it's been wonderful, and she welcomes people to contact her. That's very nice, and I think many people will start using this when the paper came out, although, you know, I think it's still harder to use in the build. So someone has to sort of fail the build before I would recommend it, but, you know, many patients, since it's a new thing, it's really nice to see that some of our patients are doing well on it. Adina says she still has improved, but she still has low blood pressure. She may want it to be tested for renin and aldosterone and go on Fornef and or take some more salt.
You said renin, aldosterone, and what else?
So the diagnosis for aldosterone deficiency would be a high renin and a low aldosterone. Some people can have a low renin and low aldosterone, and then you should get those blood tests. And if you have symptoms of it, it's pretty easy to take more salt. If you have low blood pressure and passing all the time, you know, even without your doctor's cooperation, you could start by taking more salt. Licorice and licorice root and grapefruit juice, block the cortisol breakdown in the kidney and get more cortisol to bind to the aldosterone receptor. So those are also good tricks to do, grapefruit juice, licorice and licorice root, to get your blood pressure up and to help prevent the passing out that one of the patients mentioned.
So Florinef would be besides the hydrocortisone. It's not instead the hydrocortisone.
Correct.
Besides,
So
right?
patients with primary adrenal insufficiency need both hydrocortisone and Florinef. One without the other is not complete. Many doctors erroneously give too little Florinef and too much hydrocortisone. The patients are feeling lousy, they have low blood pressure. The doctor keeps on giving more hydrocortisone and not more Florinef is needed. So I think in general, I see that that Florinef is underutilized and monitoring with a renin level is underperformed.
So I had my aldosterone checked, and it was very low, but I never had my renin checked. So
yeah, I would check your renin also. That should be high, but the low aldosterone seems to point that you'll need, you know, there's some salt, Florinef, or
and how much do you
licorice. Do you have adrenal? Do you have Addison's disease?
No, I have Sheehan syndrome.
Okay, yeah. So Sheehan syndrome sometimes people need aldosterone also. They often have a low renin, low aldosterone. But with your symptoms, it sounds like you benefit from certainly the salt and licorice and grapefruit and maybe some Florinef.
And what about the weight gain?
With?
I wrote a question. I was very, very fit and healthy. I'm 26 years old. I had my baby 10 months ago. and lost over 9 pints of blood, and long story. And since then, I gained almost 70 pounds, 68 pounds.
Right, and you have Sheehan syndrome, right?
Yeah, I have complete Sheehan syndrome.
Right, so you're on growth hormone?
I did not start my growth hormones yet. I'm waiting for a pre-authorization.
Right, so growth hormone deficiency, that may be a crucial factor in this. And you said you're taking 25 milligrams of hydrocortisone. That might be too much. Maybe you can cut down to 20 gradually.
And then I had 4 adrenal crises. And the last time I had an adrenal crisis, I went out to 20, and then I had a few adrenal crises, and then I went up to 22.5, and I still had such a severe adrenal crisis that they couldn't find my pulse. So then she just put me back on 25, even though she said it's not ideal, but she doesn't know what to do otherwise.
Right. I think I would try the salt and maybe the 4NF first, and then try to taper down again.
And how much do you recommend taking Florinef?
A half a pill twice a day would be a good start.
A half a what?
Half a pill twice a day. The pills are 0.1 milligram. A half a pill twice a day, and you want your systolic blood pressure to be, say, between 110 to 120. What is your systolic blood pressure usually?
My blood pressure is normal when I'm sitting down. Then when I stand up, it gets very low.
Yeah, so it sounds like you need
hypertension.
Right, so you could probably benefit from the Florinef.
So 0.05 twice a day.
Yeah.
Okay. Thank you very much.
Sure. Question was how much Cortef should be increased during delivery. I think it would be about the same as surgery, probably 100 milligrams when you're about to go into, when you're about to deliver or when you're going into labor, 50 milligrams after. The next day it would probably be reasonable to take 50 milligrams IV in the morning and maybe 10 milligrams in the afternoon. And then by the 3rd day, you should be able to cut back to a normal dose. Alicia asked about salivary point of cares. I've been seeing that in the works for a long time. I talked to somebody that had a grant on it, and the grant was ended, and he didn't think to make too much progress. She didn't make too much progress on it. But that would be great if we could get a point of care salivary cortisol test. I'm sorry, a point of care serum cortisol test, I think, or a salivary cortisol test. I think that would really advance things. Catherine asked, patient for whom will BLAs in the future regarding crisis insufficiency testing and diagnosis locally. Tests such as cortisol and aldosterone renin must be sent off my location, taking 2 days. In that instance, would the protocols and in the emergency letter be different? No, I think the crucial thing, maybe I wasn't clear about this, you go to if you have an adrenal crisis, you want to go to the emergency room and get your blood drawn, but cover yourself anyways. You don't want to wait till the blood tests come back. And then, retrospect, you can see where your cortisol and ACTH and then aldosterone was. But if you're having an adrenal crisis, you want to get treated right away, and you don't wait for the test to come back. And then I think, chronically, you want to do your renin and your ACTH monitoring and your urinary cortisol monitoring to make sure you're on a sufficient dose chronically if you have bilateral adrenalectomy. But hopefully you won't get a crisis. But if you do get a crisis, go to the emergency room and get your blood test, or just give yourself some Cortef and then the blood test on that hopefully. Susan mentions about a emergency room that wants tests to prove adrenal crisis prior to bleeding. I don't think that's particularly kind of you of them. If they're suffering and you're about to die, I don't think they should wait till the tests come back. But hopefully with a letter, patients may need to give themselves a Cortef by IM and Josh before they go to the emergency room. Try to find an emergency room that's a little more savvy with this. Kim asked a question about the hyperpigmentation, and the doctor wouldn't give her a script for Cortef. Should I insist? I think so. I think especially, if even one episode of adrenal insufficiency, it's worth having that Cortef for. Why, Janelle asked, why do so many doctors not treat hypothyroid cases and in function? You know, hypothyroid cases are complex. It sounds like you can't function day to day. You need to find a doctor that is familiar with it and that can optimize your hormones. Hypopituitarism is relatively rare, but and requires somewhat of a specialist. But you know, it's your health, and because it's such a difficult disease that all the hormones interact, I think you should go for a specialist.
Thank you.
So Christy asked the question, she takes hydrocortisone all in the morning, and she's having poor sleep, doesn't go into REM sleep, has restless leg syndrome. Is it better to take the hydrocortisone throughout the day and some at night? For instance, 2.5 milligrams before she goes to bed. I think definitely she should take some before she goes to bed. She probably needs a second dose somewhere in the afternoon or early evening, at least, plus the nighttime dose. Her cosentropin test went to 13. Morning cortisol was 3. It sounds like you do have hypopituitarism and secondary adrenal insufficiency. Any other questions or anything I missed that somebody wants to ask?
I have a question.
Uh-huh.
Hi, I was asking about possible Cushing's. Are you willing to answer questions?
No, let's stick with adrenal insufficiency today.
Okay.
Somebody asked a question about thyroid nodules. I think next time I'll probably have a Cushing's staff, but let's stick with adrenal insufficiency today.
Okay, thank you.
Sure.
I have a question.
Catherine B. asked the question, do you give a higher prescription to patients in their daily dose because with a stress dosing? I do. I try to give them a little extra, but you know, some of my patients seem to take way too much hydrocortisone. They think they're always under stress, and I don't think that's good either. So you know, you should take just stress dosing when you're really sick, and not just you know, if you're under a little stress. I usually recommend people that are doing sort of heavy exercise, or you know, going on a long bike ride or running a marathon. Probably take an extra 5 milligrams of hydrocortisone before you go. An extra half of F, I think would be reasonable. Traveling, sometimes I tell people to take a little bit more. Christy asked about breaking up a 20 milligram dose of hydrocortisone if she needed to take it at 3 different times. I wouldn't recommend that. I would get a 5 milligram dose so you could take it easier throughout the different times of the day. And I think that's the advantage of the pills that come in 5 pens and 20 milligrams. Elizabeth said, is taking blood pressure a number of times a day a good way to monitor replacement? I think it's crucial, especially the Mineralocorticoid, the 4F replacement. I would probably take it twice a day in the morning and before dinner. It aims for systolic blood pressure somewhere around 110 to 120.
I have a question.
Okay.
There's many times that I'm not sure. I know that if I get an infection that I should stress those. There's many times I'm not sure if I should stress those or not, because I don't want to take too much hydrocortisone, because I have the feeling that I'm already on the very high end of hydrocortisone, and I know that it's not healthy. So for example, on Friday I had an ingrown toenail taken care of. And when I came home, I was feeling so tired. I didn't feel sick. Like I had some real full-blown adrenal crises, and then like I was vomiting and like everything and etc. And on Friday, I just felt very tired. Like I just went to bed, and I was sleeping for 19 hours. And but then afterwards, I woke up and I was feeling fine. Like, was I supposed to take a stress dose?
You know, it's very hard to say at the time. I think you want a short-term error on taking more. If you feel like you're having an adrenal crisis, go ahead and take some more. I don't want people to pass out. I don't want people to die. Long term, you want to minimize those days. You want to be on a dose that's sort of stable, that you're not having to stress dose. And I think, again, in your case, you probably benefit from some Florinef.
Right. Yeah, that's my plan.
Yeah.
Okay.
Okay, so why don't we finish it here, and we'll record this, and we'll put it on my website, and we'll have another one maybe on Cushing's in the next couple of months. And I thank everybody for participating.
Thank you.
Thanks.
Thank you.
Thank you.
Is it possible making an appointment that I don't have to fly to Los Angeles, or is that not possible?
I don't think that's possible. I think you should come out and fly. For only the first time. My malpractice insurance doesn't allow me to see patients without seeing them first, unless they live in California. But
Okay.
I think in your case, I would come out and see you.
Okay. I don't know if I can do that, but I'll try. Thank you.
What did you want to ask?
Thank you very much.
Yes.
Thanks.
Thanks.